Hey guys, it's Taylor Collins. We're going to be learning about peptic ulcer disease today. So what is a peptic ulcer? It's the erosion of the mucosa of the duodenum, lining of the stomach, or the esophagus. I'll draw a little here. The duodenum, the ulcers are going to be more down here. This shows where they'll be if they're the stomach ulcers. And then, of course, we know the esophagus is up this way, some more up higher. Those little circular spots of erosion, those are the ulcers. And this up here is a healthy one. How does it happen? So they have been, the cause used to be unknown. And they have been able to determine that most peptic ulcers are caused from the H. pylori bacteria. But some other causes can be stress, smoking, corticosteroids, NSAIDs, alcohol consumption, pernicious anemia, and as with a lot of things, genetics or family history. We're going to watch this short little 1 minute video here to kind of give us some more information.
Food enters the stomach from the esophagus.
So this one just kind of shows about the stomach ulcers themselves, but it kind of breaks it down for you.
So its nutrients can be absorbed in the small intestine. The inside wall of the stomach is protected from the acid and enzymes by a mucus lining. Ulcers come about as a result of an imbalance between the stomach's digestive juices and the factors that protect its lining. Symptoms can include bleeding, and on rare occasions, an ulcer may completely erode the stomach wall. The bacteria, Helicobacter pylori, is a major cause of ulcers. Treatment typically includes medications to suppress the stomach acid and antibiotics to eradicate the infection.
All right. So let's get back here. Oh, it started us over, didn't it? Okay, so what exactly happens? That video kind of broke it down for us a little bit, but the mucous membranes can become so severely eroded that the epithelium is open to the gastric acid and the pepsin, which can cause bleeding or even perforation. You can kind of see how it starts out, gets a little more irritated, starts eating away, then it looks real bad. Signs and symptoms, we're going to hear our patients talk about that dull gnawing pain in the upper abdomen, and it can even radiate to the back. They're going to feel like they're having heartburn, they're going to be bloated, nausea and vomiting. It can also feel like an unexplained fullness, like you feel really, really full but you haven't eaten, or even like an uncomfortable sort of hunger. The subjective data, we kind of went over this. Epigastric pain, that gnawing or burning after eating, heartburn, constipation. They could report tarry stools. They could report feeling full all the time, and unexplained weight loss, which once again, if you feel really full all the time, you're not going to eat and you're going to start losing weight. And then that dysphagia, which is just the difficulty swallowing. There's not as much objective data. This peptic ulcer disease is more symptom based, but you're going to see bleeding and tarry stools. Their blood counts are going to show anemia. They could have some vomiting, and you could see some hypovolemia on their labs. Diagnostic tests, so they can do labs such as a gastric sample of your gastric contents or stool samples to check for that H. pylori bacteria or any other type of gastric bleeding. You could have blood in your stool, blood in your emesis. They're going to watch your labs, your H&H, to check and determine if you have blood loss. But the main thing is this right here, this EGD, because they need to view it to diagnose it. So we know that an EGD, they're going to run a scope down, they're going to look, and they're going to see if they can see any of these ulcers. As you can see here, and if it's an esophageal ulcer, they're going to see it a little higher up here. Stomach ulcers are going to be more here, and the duodenum ulcers will be, more down here. So some nursing interventions, we're going to encourage them to stop smoking if they do, because we do know that smoking irritates it. We're going to monitor their labs, decrease their environmental stress, and encourage rest periods, because we talked about this. Some of the causes can be stress, and we're going to administer all medications as prescribed. Some of the medical management, they may, in more severe cases, need an NG tube just for some NG or for some GI rest. They can be on some histamine 2 receptor agonists, such as the Tagamet, the Pepcid, the Axid, or the Zantac. They could be on antacids, such as milk of magnesia, Tums, or Mylanta. The sulfacrate, that will coat the ulcer and protect it. That's kind of one of the ingredients sometimes in our GI cocktails we talked about in class. And proton pump inhibitors such as omeprazole. Another medication that they could be on that I didn't put in here, but we definitely need to address, is antibiotics. If they do have that H. pylori bacteria, then we are going to want to treat that bacteria. We're going to want some antibiotics on board to get rid of the H. pylori. And then this last bullet point here, there used to be an elective surgery that was an option for these ulcers, but they have kind of steered away from that. Now surgery is usually emergency based, and it will be tailored to the patient. If they've got one that has perforated and they're having a lot of GI bleeding, then that patient's probably going to be taken back for emergency surgery, and that surgery will be to stop the GI bleed. So there's not really one specific surgery that they can do to cure the ulcer per se. It will be symptom based and only in emergency cases. The patient teaching, we've already went over a lot of this. We're going to teach them to avoid alcohol, tobacco, drugs, also spicy or acidic foods, all those peppers, tomatoes, lemonade, all that is going to burn. They're also going to want to avoid caffeine and carbonated drinks, because those can make them worse also. We're going to teach them to take all medications as prescribed, even if the symptoms subside. We're going to want to avoid NSAIDs. And one big thing, we talked about this in class, but with their antacids, like their Tums, we want to take those 1 to 2 hours before or after other medications. And we're also going to, of course, advise them that if they see any bloody urine, stool, or emesis, to report that to their provider right away, because it could be caused by, a perforation or something from one of those ulcers. When the underlying cause of the ulcers is addressed, the prognosis is very good. So if we can determine that the patient has H. pylori and we can get rid of that bacteria and get their stomach healing, then it's a very, very good prognosis. These patients, you aren't usually going to see anyone pass from ulcers. It's more about finding the underlying cause of what's causing the ulcers. But studies do show now that treating that H. pylori and avoiding outside factors that can cause the excess acid secretion has decreased the chances of an ulcer reoccurring to only 10 or 20%. That used to be a lot higher, but they have learned now if we can figure out the cause, get rid of the cause, there's only a 10 to 20% chance that these ulcers can reoccur. And then this last slide here is just my resources from where I got all of my really cool pictures. And thanks for watching, guys. Hopefully you learned a little bit.